We're going to now learn about iterative reconstruction. From a radiologist point of view, this is Sarabjeet Singh to tell us about that.
So we're still not done with the SAM stuff. I have 3 questions coming up.
Sorry.
Oops. All right. First of all, thank you everyone for coming for the CT Dose Summit, and I hope you learn new facts and strategies for CT scan parameter optimization. So these are my disclosures, and since I have roughly 25 minutes, I'll try to cover most of the iterative recon techniques, and I'm sure all of you in this room are aware of the CT imaging chain, and I will just talk about in the next 25 minutes is how we take this sinogram data and recon a 2D image out of it, historically and what we are doing presently. So I'll start with the standard or the conventional filtered back projection. It's the conventional because it has served us pretty well for the past 40 years, and we have been using this technique. So let's say I'm trying to scan this circular focal spot, and I have these X-ray projections, different angles. And we record the line integrals, and we have different set of projections. That's the sinogram data. Now we back project this in an image domain, and if you try to reconstruct this, so this circle almost looks like a star, and even though if I have more projections, I'm still not able to get the exact circle back, which is a very famous known, the star artifact, which is known back in 1970s or so. And for the sake of simplification, I'm just putting some pixel values over here, trying to say that the central pixel values are brighter and the outside are less intensity, and for that reason we need some sort of a filter, and hence the term filtered back projection. So either we can just simply back project without any filtration, or we do some sort of filtration. In that algorithm, what we do is we do Fourier transform of each projection, and we do filtering in the frequency domain, and then we do an inverse Fourier transform, and then finally back project and sum the image. So starting from sinogram, either we can take a route of filtered back projection, which we have been doing for the past 40 years, or we can take up this newer iterative reconstruction algorithm. I'm just going to say for simplicity, I'm going to call them as IR, which have a better defined mathematical estimates, and you have multiple loops of iteration over here to get your final image. Now, the toughest part which I had to do for this talk was I wanted to classify the presently available IR algorithms, and the only classification I could find in the literature was back in 1975 in Radiology Journal, which classified the CT reconstruction algorithms. And if you're aware of any newer classification, I'll be more than happy to learn and discuss with you about any new classification. So what this classification in 1975 said is either we have a back projection method, or we have iterative method, which included a simultaneous iterative recon technique. It has the algebraic recon technique. This was the technique which was used in the first version of the EMI scanner. So IR has been there for a long time. And then we have the iterative least square technique, and then there were analytic method which included the filtered back projection and the 2D Fourier recon. So based on this classification, I'll start off with the first SAM question. It's a pretty simple question. Which of the following is the iterative reconstruction technique, which is based on the classification from 1975? Yeah. We'll have enough time to think and discuss about these techniques. Out there. No. Technical error. I'm not able to move on. I'm not able to hit this next slide with this. Oh. I'll blame it to the Mac to PC conversion, I think. But while we are trying to fix this out, but I think with the... I can... Okay? All right. Since we don't have the timer and everything, but I think the answer is pretty simple over here. It's the algebraic reconstruction technique, which is classified as the IR algorithm. So moving on. So let's look at the historical perspective of CT and IR. Starting back in 1967, where Bracewell and Riddle introduced the filtered back projection, which was used for radio astronomy. And then 1970s, Gordon introduced the algebraic reconstruction technique, which was used in the first EMI scanner. But a filtered back projection, or the FBP, was used for the CT imaging because we had good enough signal, and for emission tomography we had low signal, and that's where the IR developed and refined in 1980s. And to my best knowledge, I think somewhere around early 2000s, when we were trying to lower our doses and we ran into this domain of low signal in the CT, and we had this computational power coming up with higher GPUs and higher PCs coming up, and that's where the transition of IR, or we rediscovered the IR, came back to the CT domain. In the next 20 minutes, so I have to cover basically, I don't want to leave any of the IR techniques from different vendors. So GE has ASiR and MBIR. Philips has IDOS and IMR. Siemens has IRIS and Sapphire. That was the order they were introduced. And Toshiba has ADER, and then we have some scanner neutral techniques like SafeCT, and then MGH has their in-house MBIR. So I'll try to cover these techniques quickly with a few examples. So let's go with ASiR, which is the GE technique. What the algorithm here, the better mathematical estimate, what says is that for filtered back projection, FBP, we assume that the focal spot is a very infinitely small spot, and we ignore the voxel size, and we assume that the detector is actually the central part, the exact geometric center of the detector is actually detecting to actually make a line integral. But in actual world, the focal spot is 1 by 1 millimeter roughly. And the voxel size depends upon your field of view, your slice thickness, which can be anywhere from 0.9 by 0.9 by 1, and your detector cell spacing, or the active detector area, is 80%. So it's not exactly the line, and these are the correction which is included in ASiR. And they also include a better or a more refined noise model. For FBP, we have a Gaussian model, and for ASiR, we have a Poisson model, where it's mostly for the photon noise, where the photon-starved measurements have a relatively reduced weighting in the reconstruction. And in fact, they use a compound Poisson and a Gaussian model. For Gaussian model is for the electric noise, and this is for the photon noise. So these are the mathematical corrections which they have in the algorithm. And let's look at the result of how ASiR behaves in the abdominal CT. So this patient was scanned with 4 different dose levels, not to get alarmed. So what we did with these 3 different dose levels was we just scanned the 10 centimeter of the liver. And now let's look at how, first of all, when we lower our MA, the image noise increase in the liver parenchyma. And this top row is a reconstructed of the filtered back projection. And even though it's hard to miss this hemangioma in the liver, but you can see the hepatic vessels tend to disappear at low doses. And when we process them with ASiR, if you correspond with every dose level, your image noise has gone down. So then that's one of the key effects with ASiR, is that image noise goes down, and especially with the large soft tissue organs like the liver over here. But the visibility of these small vessels, they tend to disappear, and the image tends to get blurry. So the key message from here is that it's very important to pick up the right dose level and pick up the right IR setting. So, and let's look at in the chest. The patient was scanned at 150, 110, 75, and 40 MAS. So first of all, it's very difficult to find differences between these 4 images, and that's an advantage in the lungs. You have inherent background contrast. You have air in it, and you have very sharp standing out vessels. So the noise doesn't affect much in the lungs, but if you look carefully, there's probably a few dark pixels over here. And when we process with ASiR, and these pixels have probably gone, now we look a little bit smoother lung parenchyma over here, without affecting the visibility of these tiny nodules. And ASiR is available with a blending interface. So what this tool basically does is, if you want to pick up ASiR 30, you take 70% of filtered back projection, and then it's a very nice tool which gives your radiologist a choice to say where I am presently right now and how I can go with the increment of like around 10% or so. And this is how it behaves when you use different ASiR settings. So it's the same patient, the top row is scanned with the different MAS. This is 50 MAS, this is 100 MAS, and this is Recon with filtered back projection. And now as we keep on increasing our ASiR levels, as you see at this dose level, 100 MAS, the image noise has gone down. So another key important message over here is that it's important to pick up the right dose level and the right ASiR settings to make the image quality acceptable. And this is a protocol, example protocol of how we are using ASiR in our institute. Before the introduction of ASiR, we were already scanning our kids with this color-coded protocols, where we were doing was the first time the kid comes for abdominal CT, we used to scan them with a pink zone. If the child is coming for the first chest CT, we have a little bit lower doses, and a follow-up abdominal CT where we have some prior knowledge of the kid, so then we also lower the doses. And if there's any multiple follow-ups, then we used to use the red zone protocol where we had the doses really down. And all of these zones had different weight groups, so these parameters were optimized by weight also. So what we did with the introduction of ASiR was, like on the GE scanner, we said, these are our noise indexes before using the ASiR, and then we bumped up a noise index a little bit, and we lowered our MA. So the vendor has some sort of calculation for ASiR 30, you would probably use 10 or 20% of your dose dial down. So this is the protocol how we use for ASiR in kids, and here example slide. This patient had this large soft tissue mass, which was probably neuroblastoma. And a pre-op CT was done with filtered back projection. MA was around 160, a KV of 100, and the post-op scan was done with 80 MA. Everything else same. The CTDI dropped from 10 to 4, roughly 60% dose reduction, and a pretty comparable image quality. And I think noise is pretty much the same in the liver. And here's an example of a head CT with ASiR. This 18-year-old boy had some subarachnoid hemorrhage, some subdural hemorrhage. And the prior scan was done with filtered back projection with a CTDI of 65, and the follow-up scan was done with a CTDI of 25. So that's sort of 60% dose reduction if you take the CTDI numbers. And this was Recon with ASiR, so and a very comparable image quality. And I think noise is probably a little bit less on this side. So this is our experience with ASiR. In chest, we felt we can go down to 40 MS compared to our standard, which is 150. In abdomen, we could go down to 100 compared to 200. And in kids, we could go down like roughly 40 to 30 dose reduction based on the CTDI. Moving on to Siemens, which is the next vendor, and they introduced the iterative reconstruction technique, namely IRIS, which is IR in the image space. Very simple algorithm. Take the sinogram, get a master recon, and the loop is in the image space. So all the corrections are made over here to generate the final image. Here's an example of IRIS, where the patient was scanned at 200, 100, and 50 MAs. Noise goes up, and you have this low attenuation splenic lesion. A fairly decent-sized lesion, hard to miss. But the message here is, if you recon with this IRIS, your noise goes down. So it lowers the image noise. And then Siemens also introduced the Sapphire, which is the sinogram affirmed IR. Basically, this algorithm combines a raw data approach with an image-based loop, and it uses a maximum likelihood model to obtain some noise-free base information and additive statistical noise. Solve this iteratively, and then estimate the noise, subtract this, and basically these are the loops which control the strength of your noise reduction. 1 being the weakest and 5 being the largest. So the setting doesn't mean they are the number of iteration; it means the number of noise reduction, the amount of noise reduction. And here's an example in Sapphire. So we have this patient was scanned with 2 different dose levels, 97 and 31 MAS. And these was a recon with filtered back projection. So image noise goes up in the liver, and you have poor visibility with the small structures over here. Now this raw data was processed with Sapphire 1, Sapphire 2, Sapphire 3, Sapphire 4. And as you see, as we keep on dialing up our settings of Sapphire, the image noise goes down, but it affects the visibility of these tiny vessels over here, and the edges get blurred. So another important message over here is it's very important to pick the right setting of Sapphire before we discard saying that this technique doesn't work for the visibility. So probably in this case, like even S2 or S3 would have worked if you're comfortable with this noise and the visibility of vessels. Here's another example of Sapphire. This patient was scanned with 110 MAS and then 40 MAS, recon with filtered back projection. You have multiple liver mets. I don't know whether if you can see, there is a central necrotic region and there is a peripheral rim at this dose level. And even in this lesion, you see a peripheral rim over here. And when we recon this raw data with Sapphire settings, so even though the noise has gone down in the liver, but it doesn't bring up that rim back. So this is something which radiologists are looking for, is that now they are well trained. They see that the IR is reducing noise, but they're very picky or very particular about picking the visibility of small structures or lesion margins. And this affects the visibility of the lesions too. And here's an example in the mediastinum, a chest CT scan with 140 MA, and Recon with filtered back projection, and then you have different SAPHIR levels over here. You have a local little pleural diffusion, and which is hard to miss, but we see the edges are a little bit more well defined. And when we do any sort of analysis, or subjective analysis, when you show this images to a radiologist, I think the most important thing is they want to see that, okay, noise has gone down in the mediastinum in all these structures of the heart, but they want to see the edges as sharp and crisp as this one. Only then they can call these two images as comparable. So the message here is IR does reduce noise, but be careful to look at the visibility of tiny structure and the edges. And let's look at example of a chest CT. As we saw earlier, it's very hard to find differences in the different images. These patients were scanned at 100 and then 40 MA, and probably you see a little bit of dark pixels over here in this lung parenchyma. And this is processed with different SAPHIR settings. And in terms of noise, it's very hard to find differences, but if you notice this lung fissure, which is completely gone at this setting. So this is a literally disappearance of a major structure in the lungs, which is definitely not accepted by any of the thoracic radiologists. So it's very crucial to pick up the right setting. Probably even I can say I can kind of hallucinate that there's a fissure over here based on the prior knowledge. But the key message here is you're lowering noise, but be careful about the visibility of smaller structures. And let's move to another vendor, which is this Medic Vision from Israel, and they have this image-based IR. Instead of going into detail of the whole algorithm, they have some sort of maximum likelihood function, a fidelity term, a prior term, and then decompose the CT images into 3D patches and then estimates the noise and separates the noise. And here's an example of how this algorithm works. So this is a post-mortem CT done, abdominal CT done at 200, 150 MAs, and we recon this data with a SafeCT algorithm, and we see the noise has gone down. But if you look at this pancreatic contour over here, the edges of the pancreas looks blurred. And this is an example of brain CT, post-mortem brain CT, large MC infarct. We have 140 kV and 150 MA, then 120 kV and 150 MA, and filtered back projection, 120 kV and 75 MA. So definitely more noise in this raw data, and we took this image and processed with SafeCT with different settings. So this algorithm also comes with different settings, and we can see as we keep on increasing the settings, the image noise goes down. And very comparable, the small sulci and gyri looks pretty comparable to the distose level. Moving on to Philips, they introduced first the iDose. This algorithm basically starts with the projection data. It identifies and corrects some noisy measurements or projections, which can be either due to poor SNR or low photon count. And then it updates the raw data. And then it goes to the image domain and basically lowers the quantum noise or the image noise, and while preserving the edges. So it includes some sort of a structure or anatomical model, and it has a multi-frequency model-based noise removal. Let's see how iDose affects the abdominal CT. So this patient was scanned at 250 MA, 120 kVp, and Recon with 5 millimeter slice thickness. And we can see that the image noise has gone down. So iDose also comes with different settings, I think from 1 to 7. And we're using iDose setting of 4. And this patient was scanned at 190 MA, processed with filtered back and iDose. And we see that the image noise has gone down. And you can see the multiple low attenuation lesions here, the spleen heterogeneity. And Philips has also introduced the second version of their IR, which is the Iterative Model Reconstruction, commonly known as IMR. And this algorithm also comes with different settings, namely 3 different bins. One is a low contrast setting and one is a sharp setting. And then you have a combo setting in between these two. And each of these settings has different noise reduction levels like L1, L2, L3. For the sake of simplicity, I've just taken 3 different bins, and we've reconned this raw data from Philips scanner, which was acquired at 120 kV, 300 MA. And if you see if the posterior part of the lung paces, streak artifacts caused by the vertebral body, with this setting, probably it's not disappearing, but over here, they're significantly reduced. So key message here is, again, that it's important to pick the right setting of IR for the desired effect which we want in the image quality. And we don't have a Toshiba scanner yet, but courtesy Toshiba from Erin and Design and Satyajit Mishra have the algorithm over here, where they also take the projection data, include the scanner model information, statistical model information, then they get into the image domain. I think this is the adaptive part, and this is the iterative part, so that's the name, adaptive iterative dose reduction, ASiR. And it loops around over here. It has got some blending tools. And this is how ASiR behaves in abdominal CT. This is abdominal CT in the pelvic area. We have lots of streaks and artifacts over here, and the noise is roughly 80, and we process this with ASiR. noise has gone down, and we can see this effect also goes along in the liver parenchyma. So the message is IR does reduce image noise here too. So this takes me to the next time question. Hopefully it will work this time. Let's see. So the question is very simple. Which of the following techniques lower image noise? Is it decreased dose flux, or IR, or thinner slices, or sharper kernels? I have enough time to think about it. Let me know if I have to hit the next button for this. Sure. Okay. Okay. Sure. I think in the interest of time, I basically wanted to say that I had to rush through literally all the techniques, but any time during the breaks, if you have any question, and keep a low threshold to contact either me or Dr. Kalra about any of these techniques. Okay, so I think it's open. It's a timer over here. Advance. Okay. All right, perfect. I think almost everyone got the answer right. Moving on to the next slide. This is the right answer. IR does lower image noise. I have a few more minutes to discuss quickly about the MBIR, which is this technique from GE, which is the fully IR. It includes the system optics information. It includes the statistical models, the desired image behavior. It's got some regularization term over here to generate the final image. And let's see how MBIR affects an abdominal CT. So on the left side, you have this dose is 200 MAS, Recon with filtered back projection, ASiR and MBIR. On the right side, you have FPP, ASiR, and MBIR at 50 MAS. Now, clearly you can see that ASiR probably lowers the noise a little bit at 50 MAS, but with MBIR, there is almost no or minimal noise in this image. Now, if you look at this tiny low attenuation liver lesion, so it's not difficult to detect this also. So the message is you can still detect tiny lesions, but what it's affecting is the lung parenchyma. So this image is clearly not as this image, what radiologists are comfortable reading. So now there are different terms used to identify or kind of point out to this texture, which is a different look, a plasticky look, a blotchy look, or they'll just call it just a different look, even though I see the noise. If you ask a specific question, is the noise gone down? Yes, noise has gone down. Can you see a tiny lesion? I can still detect a tiny lesion, but we cannot call it same as this one. So I think that's where more work needs to be done with the IR is how do we optimize the algorithms to get the same image quality what we were used to looking at. And once again, in the lungs, this is top row is with filtered back projection. This one is with ASiR. This one is with MBIR. Hard to find any differences. And if I zoom up to this level, which we rarely do in the clinical practice, but we see that we do see some of these tiny dark pixels, which could mimic an emphysematous disease, which has gone down with MBIR. And in fact, if you look at this left main stem bronchi, you see some dark pixels over here. This is just pure air, and it should be like this. So we don't know right now what is the ground truth in the liver parenchyma. Is it liver supposed to be that smooth, or is it just the technique which is causing it? Because air is supposed to be purely black. Here's a slide again to show the effect of MBIR. This is Recon with 200 MAS, filtered back projection. This is a low dose image. Recon with ASiR, noise probably the same, and with MBIR, noise going down. Now, in this liver parenchyma, we see is that these tiny pixel holes, which is also seen with this noise, but it's just a new look of the liver, which makes a GI radiologist not so comfortable saying that, I don't know whether this is a different kind of pathology. And also, if you look at this renal fascia over here, it's not as sharp as it should be. So that decreases the confidence of a reading radiologist. And if you look at The top row is 150 MAS. You have filtered back projection, ASiR and MBIR, and the bottom row is 40 MAS, filtered back projection, ASiR and MBIR. So once again, you see multiple lesions in pathology over here, but you don't see much differences even if you dial down to any structure. But what you see a difference over here is that the lung fissure is disappearing with MBIR. So this we have noted consistently with both SAPPHIRE from Siemens and MBIR from GE. And we have conveyed this, and they are still working on the algorithm to retain this structure's visibility. And we did some sort of noise power spectrum or noise spectral density analysis. And to a layman, if you say this is filtered back projection, this is ASiR, the texture roughly follows the same. With MBIR, the noise pattern is different. So one is we can say the noise goes down, and another thing we can say is the noise pattern is more uniform or more regularized. So this takes to the next SAM question. Which of the following is true about model-based IR? I'm referring to the GE's Veo. First response is increases the HE value significantly as compared to filtered back projection at the same kV. Second one is does not include the system optics and hence faster recon time. The noise spectral density show lower noise and more uniform trend as compared to FPP and ASiR, and effects of lesion detection on tiny attenuation focal lesions. So, Shahid next. And your time starts now. So I think most of you got the answer right. It does lower the noise and it has a more uniform trend. And for those of you who were a little bit distracted with the last point, it affects the lesion detection. So this is the message I'm trying to show over here is that IR lowers the image noise, but it does not affect the visibility or the detection of a tiny lesion. This is our experience with all the IR techniques at MGH. We started off with ASiR, and so the ASiR and Veo from GE and Siemens and SAPPHIRE from Siemens, Iris and SAPPHIRE from Siemens, and Philips we have IDOS and IMR. So what we're doing presently is we're scanning routine chest CT with this MA range of 250 MA max and 32 noise index with the ASiR setting of 40. And then we're using ASiR setting of 30 for routine abdominal CTs with those levels. And the brain, we're a little bit more aggressive. We're using ASiR 90 with these dose levels. And it's pretty much instantaneous. The images come right away as you hit the ASiR Recon. But with Veo, we see a little bit larger recon time, and that's why we are still trying to explore the conditions where we could use. So the indication where we're using Veo right now is kidney stone, and I recently found out we are using also in CT clonography and any of the abscess drainage follow-up, and these are our dose levels for Veo. So very limited indication because of this largest recon time as of now. And Siemens has Iris, which is also instantaneous. We don't have this technique as of now, but there are other institutes I'm aware they're using. And SAPPHIRE, we do a routine chest CT with this reference MAS at S2 setting. With abdomen, we're using S3 setting, and with brain, we're using S3 setting. With Philips, on the ICT scanner, we have the IDOS, where we're doing a chest CT at 100 reference MAS, or 100 MAS with IDOS 2 setting, and abdomen at 100 MAS with IDOS 4 setting, and brain we're using IDOS 3 setting. And IMR, we have offline recon box, which takes roughly 3 or 4 minutes. I'm not sure on the scanner how much time it takes on the scanner. I'm still in touch with the Philips to find the exact time of recon. And we don't have Toshiba as of now, but it's real time, very instantaneous images are generated out of it. So 3 key messages over here is, first of all, IR lowers noise, but be careful with the visibility of smaller structures. Optimize your setting based on your dose, your present doses in the institute, and the different body regions. And then finally, work with the radiologist to fine-tune your image quality. Thank you.
Do we have any questions? I was looking for some of these slides in my handout, and I couldn't find them either. So if you're wondering about that, the final version will be available online after the conference. So don't sweat that. Because I know there's a lot of really good tables in there that I'm going to want to dig out and look at carefully.
Would it be correct to say for even the most difficult imaging tasks that iterative reconstruction can produce perhaps at least a twofold reduction in patient dose?
If the word is twofold, I can say yes. Depends upon where the standard is. If the institute is already at 300 MAS for a chest CT, we can easily go to 150, and we can call twofold reduction in doses. But I think I want to answer it in a more, call it scientific ways. Instead of using a twofold dose reduction, it's better to look at where your present doses are on the scanner, and then look at your IR algorithm. And based on that, you can even go probably threefold or fourfold dose reduction.
Thank you.
Thank you.
So one of the things we've been trying to do with these CT dose summits is to give people some ideas of what's an appropriate dose for a specific exam. And that's been really hard up until now, and I think you'll be seeing more and more real dose values coming out as we go through the sessions today and tomorrow. So keep your eyes out for that if that's really some of the information that you're looking to get from this conference. The next thing we're going to do is take a break.